I don't know whether we really forgetted it to now to rape. For us who are dealing with these patients, we have not seen rape patients actually resulting into a fistula. We have had some defiant babies getting perineal tears. So, but we also know in trauma, we have road traffic accidents that show towards injuries from falls, trees, and so on, that we record, and we recorded some in 2023. So could these have been confused? Otherwise, thank you for the report. It's
procedures from these surgeons. We need to first enhance and build capacity of the regional referral hospitals fully, so as that we harness from their resources than making just an assumption that the regional referral hospital will do a skills enhancement. I thank you.
Thank you. The last question.
Both of the parties have been accused of not being honest. The health providers have been accused of not being honest, and also the other side. So whenever we talk about health insurance, there is a lot that needs to be planned fast and addressed before rolling out, especially if it is to be the national health insurance. But I must say that we need...
There were some questions you might want to address or highlight, especially on the issues of services. Is there anything you want to say before we wrap up the session?
Thank you, Session Chair. Mine is an additional component to addressing the issue of iatrogenic fistulas, which Richard and Ronnie elaborately talked about. But importantly is the issue of skilling through attachments that we've already started working on as the Ministry of Health. Solutions that we came up with in the last sectoral conference that was focused on strengthening health systems to deliver quality around to the population. I will briefly highlight, these are entitled in the report that we are going to launch this morning, and we should be able to find it in an online version of this report. But I want to thank all partners who have been very helpful towards this. So our theme for this report is really addressing delays in care to improve. At one time it had become a hostel to host nursing students, but with our interventions, now that theatre is fully functional, and you can see the team there is now smiling because the services have been restored. We've been able to operationalize a number of health center force. We are an action-oriented group. We commit to changing each and every facility. If we find challenges, we address them through the small steps. And we've been able, in the last year under review, Patongo Health Center 4 is now functional as a Health Center 4. Mpumu, the Health Center 4, with the support of our partners, is also functional. Rukoki, which has gotten its maternity band, is also functional. Kaserem, as highlighted, those are health center 4s that we've been able in the previous year to turn into functional health center 4s. We've also been able, we can account for the number of NICUs that we've been able to functionalize, newborn care units, and we are reducing the number of facilities without blood storage facilities. And this is about the human resources. Madam Chief Guest, we've worked with the districts. We put them under, I call it minimum fraction. The districts have been put under minimum fraction. Some of them, their facilities have been suspended. I remember telling the DG that we are going to suspend some facilities. But in the course, they've been able to recruit. When you suspend them, DG, they actually recruit. We see it to be a testament. We suspended their activities and they recruited an athletic officer.
When we go to the pathograph, you know that the pathograph is very important for monitoring labor and therefore the outcomes that we expect. We note that we have not done a good job of pathograph use at higher levels of care, And this is where we have our trainees and other interns and all these other areas. And so we need to work on improving labor care at that time. We have only 34% of mothers monitored with a pathograph, a decline from 43. And also we note that the quality Woman Member of Parliament for Literacy.
A professor of obstetrics and gynecology.
Being the founding director of Save the Mothers Uganda Christian University, Mukono, where I work with outstanding individuals like Florence Marindi, Pius Okong, Dr. Olson Zimula, Justice Barrett-Guiney, who's with us also today, and other key leaders. And who have really helped to grow the Save the Mothers program as an effective movement for strengthening community engagement. I will share examples of the lessons learned from the Save the Mothers team and experience. I acknowledge I'm a Canadian OBGYN. I'm faculty at McMaster University, but I've lived in Uganda for 12 years and have engaged in safe motherhood activities here in Uganda for the last almost 30 years, working with the Association of OBGYNs of Canada. I also lived in Yemen and other low and middle income countries. So all of these experiences have influenced my perspective as well. If I could just tell the technical team, I'm sort of flashing down here, if we could help with the screen here, I'd appreciate it. Well, what I hope to accomplish over the next few minutes are really three things. To review the essentials of safe motherhood, what's new and what's old, and we've already reviewed a few of those already. Recognize the strengths and the barriers of community engagement. And finally, discovering and reviewing the essentials of effective and sustainable community engagement. So there's two sub-themes that I would like to talk about, and that is becoming strong and staying strong, and really addressing the three traditional maternal mortality delays. The delay in the home, the delay in the getting to the healthcare facility, and then the delay at the healthcare facility itself, and we've already been talking about those already. Well, I would suggest that those two themes can be really looked at carefully by looking at the examples of long-distance runners. And of course, we think of our Ugandan Joshua Cheptegei, who won the recent 10,000-meter, it's a long run, gold medal for Uganda, and rest in peace, our dear sister Rebecca Cheptegei, who is also a marathon runner. Well, you might ask yourself, what does marathon running and long-distance running have anything to do with safe motherhood? Well, actually, it has a lot. It has to do about getting strong and staying strong. Safe motherhood isn't just about taking care of people right now, but it's the long haul. You can't take a temporary rest in the middle of a marathon run. You have to push through even when it hurts. And the race includes looking ahead. It's preparing for that next generation, the next 25 years, staying strong and in fact becoming stronger. And as we look at the increasing population in Uganda, we need more resources to care for mothers and babies in Uganda. And it takes discipline and future planning, just as these marathon and long-distance runners did. So if we look at the current population of Uganda now, it's nearly 46 million people from our census this year. Today, the average Ugandan is 16.7 years of age, and these young people are soon going to become parents. So if we think about in 2050, there is going to be 100 million Ugandans. You think about that's doubling the population, doubling the number of mothers based on the current population growth. The safe motherhood players are going to need to run really hard and really long to help. Well, what can we learn from other people, both their successes and also their failures, even if the failure is simply a failure of poor planning? Well, let me refer to two cities in Ontario, Canada, where close to where I live. The first one is Waterloo, home of the Blackberry, many of you know, and the second is London, Ontario. So in Waterloo, they had a decision about several decades ago what they were going to do with their road system, and they built this extensive road system that has really allowed their city to grow and to develop, and for people to really feel good being able to get around, and the economic growth has increased. Compare that to London, Ontario, where they decided they could not have a highway go through their city, and so therefore people are now sitting at the train station, or in front of the train as the train is passing by on the major roads. So again, one has had growth and you have happiness, and the other is basically poor planning and now lack of growth. Well, before we continue to talk about safe motherhood, just want to take a moment just to think about what do we actually mean by safe motherhood. Well, of course, there's the usual definition, but I think if we just think about no mother or child should die or sustain a disability. We talked about the fistulas earlier, from preventable pregnancy complications. And we all know that this is a basic human right, that women and their children should not die or suffer from these kind of complications. Well, to become strong for safe motherhood, it really involves community engagement, and we've known that for many years, but how do we really do that? But in the context of an increasing population and potentially doubling of the number of mothers, we heard a lot about what's available in the healthcare facilities. Can you imagine a few years from now, we need at least double that amount? Well, the theme of this conference is about the impact of community, but who is the actual community? Well, the good news for the community actually is we actually have cures for many of the complications of unsafe motherhood. We have medications like oxytocin, we have misoprostol that has now come in as part of our armamentarium. We have carbetocin, again another medication that is going to become more and more used here as well too. We have some other new medications as well too, things like Fibrillar that are used to promote hemostasis or reduce bleeding. Well, again, we have some great developments that have happened and cures are there. The question, of course, is about access. Do all people, do all women have access to this care? So again, as you mentioned, we were talking about the involvement of the community. Who is the community? Well, of course, the community is people. We, each one of us, are part of a community. When we think of the various components of the community, each one of those groups have strengths and each one of them have capacities and capabilities. So let's take a little bit of a deeper dive right now and look at the various parts of the community. First of all, right in the middle, if we think about the community, we're thinking about individuals. We're thinking about neonates, we're thinking about infants, adolescents, young, middle-aged, and old. We're talking about the boys. We talked about that earlier. We can't forget the boys, the girls, men, and women, able-bodied and those that are disabled. They all have their rights and responsibilities. And you know, we don't commonly emphasize the adolescent as being part of the community or as community. We don't really think of them that way because they don't seem to be the decision makers in society. But they are making individual decisions themselves that affect. When we think about education, at all levels of education, the messages of safe motherhood and pillars can be, we know each person has a basic right to education, irrespective of their religion, gender.
And health aging, civil society platform where I held as the chairperson. I'm just completing my 1 year, and next year it will be my last year. And I will hand over power according to the 180 members who elected me. If they are asked for me to come back, I'll come back. So, as civil society, the 180 members and those who have not yet registered to be part of this platform, one is that the Ranka Plus N CSO platform is also the country coordinating mechanism for World Bank JFF as a platform. So we are not just a coalition, but we are a platform as part of the engagement strategy. We would like to appreciate the Minister of Health, led by the Minister, the PS, and all of you, for allowing us to be part and partial of ensuring better health. As you can.
So you have the floor on behalf of religious leaders, but also on behalf of the name. A big clap for also.
Thank you, DG and Session Chair. You know, the chief guest, the Honorable Minister, Dr. Lufa Chen, and the PS, Dr. Atwine, are my sisters. They're my sisters from other mothers. We share a father. All protocols observed. Praise God. Amen. From whom all life flows. My name is Dr. Joseph Sirota, and I am the presiding officer of the Born Again Faith. I'm also co-chair at the Interreligious Council of Uganda. Please accept our greetings from there. And chairman currently is His Grace the Archbishop of the Church of Uganda, Dr. Samuel Stephen Kazimba Ngaru, who, alongside 6 other leaders of the Catholic Church, the Born Again Faith, which I represent, the Muslim Supreme Council, the Seventh Adventist Church, the Orthodox Church, all come together to lead this community. It's a great honor for me to be here, to join all of you, united under this same strengthening community engagement for sustainable maternal and child health. Please allow me, before I say anything else, to voice my very personal appreciation for the services rendered by the health sector. In this country, we have those who are militarily armed to protect us from mainly external threats to our lives. Others serve Uganda in many other ways. But we all know that bullets and tanks and to a degree aircrafts are hopeless against simple but deadly enemies like malaria or cholera or diabetes and the like. So when a lady goes into labor and begins to fight to bring life to this earth, all the members of the UPDF, the UPF, from CIC to any level down there, they will just look on, their weapons notwithstanding. So please let me give a round of applause for the ministers, the directors, the commissioners, the managers, all practitioners and workers of the Ministry of Health at headquarters and across the nation. Thank you for a job well done. Ugandans have become very hard of recent and rarely say thank you. They never say thank you. Especially if they have paid for the service. Honestly, looking at the report that we saw in the first report, with at least less than 3% professional misconduct, 3% professional misconduct, and you have 97 good conduct on your side, that is a perfect score. Because I know a department in this country, I want to mention, who are performing at 155% misconduct. Very well. Now, mothers and children and adolescents, without forgetting the men, are pushed into our ministry as religious leaders and our ministries. Our pastoral work, every second, every minute, every hour, every day, is to ensure better health and lives for all. If there are allies to our religious work, your ministry stands out. We therefore commend the Ministry of Health and partners for the great strides in improving reproductive, maternal, newborn, adolescent health and nutrition, which is our NCH, especially. The efforts of maternal mortality from 336 to 189 deaths per 100, with the idea of strengthening health systems, especially community health, through the finalization of the community health strategy. And we are hopeful that this will unlock many barriers. However, we call upon the Ministry of Health to ensure that our religious leaders, who are resource persons and champions of health in the communities, are considered when selecting communities.
All protocols are observed. It is really a great honor and privilege for me to join you at this 4th National Safe Motherhood Conference. I'm representing the United Nations Population Fund, UNFPA, and UNICEF. Today we come together as advocates for maternal and newborn health. We are united by one goal, that no woman should die while giving birth. Let me add my voice to commend the Ministry of Health and all partners for their unwavering commitment to safe motherhood in Uganda. The recent demographic and health survey and maternal and perinatal surveillance and death reviews highlight significant progress in addressing maternal health challenges for the past 2 decades. We have heard from the previous speakers that maternal mortality has declined from 336 deaths per 100,000 live deaths in 2016 to 189 per 100,000 live deaths in 2022. A 43.8% decline. This is really surpassing the national targets. So this achievement reflects the collective efforts of the government of Uganda, the healthcare workers, development partners, and all stakeholders. It shows the importance of partnerships in addressing maternal and newborn health. However, preventable risks during pregnancy and childbirth persist, claiming an estimated 3,000 lives annually. 3,000 women and girls dying annually. How do we justify ourselves when women continue to die while giving birth? But many of these deaths, as we have also heard, are preventable. With access to quality maternal health care, including emergency obstetric and neonatal care, skilled health providers, particularly midwives.
So on behalf of the U.S. government, I'm really pleased to join you for the 4th National Safe Motherhood Conference. USAID and the U.S. government, we are here to reaffirm our shared mission, ensuring that every mother and newborn in Uganda receives comprehensive care needed through pregnancy and childbirth. I'm deeply humbled by the dedication in this room. But Minister Acheng, Dr. Mugahi, not just the dedication, but really the successes that the people in this room represent. The healthcare workers, policymakers, community members, my fellow development, ostentatious goal, which many thought was untenable, ludicrous, even impossible, to reduce maternal mortality in focused areas by 50%. It was built on the premise that it takes a system to save a mother, a community system, quality health facility services, and referral systems. So now the program was successful and proved it could be done. But what is so powerful to me a decade later is that Uganda went way beyond this. A decade later, you have nearly reduced maternal mortality ratio in the entire country by 50%. 44%, it's not far. So to me, this achievement reflects the power of our collective commitment and the impact of our interventions. Maybe even more importantly, it encourages us to not only set bold goals, but get them done. Look at the people around you. Look at the power and influence in this room. There is no doubt in my mind that we cannot together achieve what we set out to do for Ugandans. So the fight isn't over. Obviously, we need to continue working on maternal health to meet the Sustainable Development Goals. And we heard great points this morning, not only from the NDSR report, but also the EMOC assessment that was done this year that can guide us on how we move forward. But this progress also allows us to take pause and to reflect on really what are the next frontiers in maternal child health. So I'm not going to repeat some of the points made, but we strongly believe some of the next frontiers are ensuring motherhood is planned, and at the right, safe time, particularly for the young women in Uganda. We also believe that one of the next frontiers is ensuring newborns with their mothers have access to emergency neonatal care services. So the theme of this year's conference, Strengthening Community Engagement for Sustainable Maternal Child Health, reminds us of a powerful truth. Our journey to safe motherhood must end and begin with the communities we serve. We must walk with them, hear their stories, adopt a client-centered approach that upholds quality, equity, and dignity, and really emphasizes it's not just access to care, but quality to keep making the progress that we've made.
Don't have time. Our chief guest, our Safe Mother champions, all of you are champions of safe mothers because you are in this room. So I want to congratulate you for the milestones that we have achieved. And I know that we achieved this together. It has been our utmost pride. Want to see, can just 1 minute, I will not take it, just stand up. We want to see many. Congratulations, men. This journey cannot be completed without men. So we really want to thank you for the enthusiasm, for the support that you have given, not only just this program of the conference, but you have been walking the talk. And I want to congratulate Dr. Kenya to come and join us because you are representing the men in Parliament. So we want to thank you very much. Our partners, we want to thank you so much. This could not be possible. We will not be able to mention each one of you, but we know the role that you have played all the way. I want to thank you and congratulate you for the evolution we have seen in safe motherhood. We are having the 4th National Safe Motherhood Conference, and we are opening the 4th page. We are opening a fresh page to engage, to redefine, to strategize, to implement together. We have been putting so much emphasis at the facility level. I want to congratulate LMNS group. The evolution I'm talking about, last time we were here, we knew that, and I remember, 2 LMNS were not active. And I want to tell you that those 2 are on board and they meet every week. So I really want to congratulate all of you, the national elements, and I want specifically to thank the chairs of special groups. I see Dr. Nong, I see, how can I even mention, all of you are here. I see the faces here, that all the time, every week, you are discussing issues that are pertaining safe motherhood and the children. But I want also to congratulate NEST. Can I see members of NEST on this? Just show of hands. NEST, neonate, I'm talking about the neonatal team that have been working also, meeting weekly. Barbara, where are your teams? I'm not seeing the NEST team. Can you stand up? NEST team, NEST team. Thank you very much. Thank you so much. So we really want to thank you that we moved from just, I know that we are working on perinatal, maternal and maternal deaths together, but the emphasis always at the beginning was on the maternal. But I want to congratulate all the teams that now the perinatal reviews have greatly improved, and perinatal interventions to make sure that we see, and that's why we are able to see less deaths. And this chapter we are opening, the 4th chapter today, we really want to strengthen perinatal services. Maternal child, born together, but really for the children, we need to pay attention. We are still losing many children, and we know that that is the entry point, even to improve the maternity. You cannot improve the outcome of the babies when you have not improved the maternal intervention. So we know that that is the entry point, and it's going to help us. Today I'm excited that we are going to talk about strengthening community engagement. This year, this is our niche. A few days ago, we were in this room, we're having the Health Promotion Conference. And our theme was on community strengthening. Yesterday, when we were having the youth conference, we were talking about community strengthening. And we are excited because that is where work is. We know that at facility work is there, and we are continuing this protocol. But allow me to recognize the members of parliament who are here. Thank you very much for coming. Really, I should just declare the conference open to avoid repetitions. I think so. What do you think? I say a few words because we are all saying the same things over and over again. But allow me to warmly welcome you all to this annual Safe Motherhood Conference and to bring you greetings from the Right Honorable Prime Minister. She indeed would have loved to be here, but she couldn't make it because of other commitments. But she asked me to appreciate you, to thank you for coming, and to thank you for the good work that you're doing to end preventable maternal death. The Safe Motherhood Conference is the biggest annual convergence that is organized by the Ministry of Health and stakeholders in the reproductive, maternal, newborn, child, and adolescent space to discuss and reflect on implementation experiences and make recommendations to improve the outcomes. It also provides an opportunity to envision a future where every woman can experience the joy of motherhood safely and with dignity, whether the outcome will be good or bad. I am glad that progressively the outcomes are good. Safe motherhood, as you have all heard, is about life and continuity of humanity by making human reproduction a safe and fulfilling experience. This makes safe motherhood a collective responsibility for all of us at the different levels of society, including the off layers. Because there are some off layers in this room. We also want to see our daughters deliver safely. And the on layers, we want to see you alive. Our theme this year is strengthening community engagement for sustainable maternal, newborn, and child health, and you have heard it over and over again. It aligns well with the Ministry of Health's strategic direction of strengthening community health systems for better health outcomes. We need to work collectively with all stakeholders at community level to address the first delay, which is the delay to make an appropriate decision to seek timely health care, and
get quality services. The ministry, through the village health teams and CHOOS, will implement the community health strategy that will strengthen our community initiatives and improve health outcomes. Allow me to congratulate the partners that support newborn and child health services for their collective and dedicated efforts that have led to improvements in the indicators as seen in the Uganda Demographic Health Survey and also the census. The results provide optimism that Uganda is making progress towards ending preventable maternal and newborn deaths and on course to achieve the Sustainable Development Goal 3.1, that is reduce maternal mortality ratio to less than 70 per 100,000 live births by 2030. Health workers, including nurses and midwives. Actually, the numbers of nurses and midwives who have not yet been recruited into the system are huge. If we recruited all of them from a health center 3 to the specialized facilities, I think all our mothers would be attended to by skilled staff. But I want to reassure you that recruitment will soon be addressed in a phased manner. So take home the encouraging message and continue to discourage our mothers from the delivery at traditional birth attendants. This, by the way, we abolished in 2010. Formally abolished in 2010. But we still see them and they are still doing unnecessary work. Pastor Seruada willingly, freely has given us the media houses, the religious platforms, and many others. I am humbly requesting our teams at reproductive and child health draft for them good statements so that they can read during their sermons, it can be read on their media houses and so on, to alert mothers to avoid the traditional birth attendants. That is a free gift to us. We are not going to pay for it. And their coverage is wide. Their coverage is really wide, especially if it goes through the Interreligious Council. There are other areas that still need improvement, and I will quickly highlight a few of them. Allow me also to congratulate us on blood availability. Let us also address the issue of sale of blood. Recently, we also, the media clips of people stealing blood and keeping them in home refrigerators. We need to address that as well. So management systems in our health workforce. And the PS, we also the use of the pathograph. By the way, the best facilities were health center 2s that we are facing out, followed by health center 3s, and unfortunately, the trainers are the worst users. So the trainers, you need to up your game. 2, strengthen community mobilization for reproductive, maternal, child, and adolescent health services like antenatal care, nutrition, immunization, and family planning. Let us not forget nutrition, and nutrition. If our mothers are not healthy, the outcome will not be good. And I am glad that I saw a nutrition booth right there. But instead of seeing the varieties of foods, I was seeing supplements. Is the strengthening of the village health teams and community health extension workers to create awareness, to empower women and families to make quick, informed choices. These workers, as you're all aware, play a vital role in bridging the gap between healthcare services and households. By strengthening their training and support, we can enhance their capacity to advocate for safe motherhood practices and child health initiatives effectively. I will pause here and again thank our partners, both development and implementing, for your commitment to support this initiative. I am sure that the future will not be the same when we have this cadre well-trained.
Honorable Minister, whoever was on the high table, the side and side, yes, at the same time. Some can start from there, coming this way, this one going here. Development partners, civil society, Parliament,
Don't worry about them. They are all coming.
Dr. Mjeni.
CSOs and IPS.
I'm gonna
Just one more category.
For you. Hi, Dr. Martha. We wanted
yeah, let's have
Was there any plan to avail them with Sayana before they go for implementation at the community? Because as you talk of stock out, that shows that the VHTs that have been trained, when they go back to their nearest facility, they will not be able to get. Was there really any plan? Because they have given them really high target for monthly data reporting. Thank you.
Many abbreviations for the sake of making your presentation.
Bakar University, and our study site was Kawempe National Referral Hospital. We saw that mothers who had previous uterine scar were at high risk of uterine rupture, and therefore we needed to put special attention to this category of mothers. The same study that was done at Kawempe by Namagebe 2022 revealed that 37% of the deaths that occurred from uterine rupture had the previous uterine scar. And this due to the increasing skyrocketing C-section rate in Uganda and also worldwide, which are projected to be 28.5% by 2030, gives us a special attention to understand how prepared these mothers with the previous scar are. So this was a facility-based cross-sectional study that was conducted at Kawempe National Referral Hospital Clinic, and the mothers with the previous scar above 37 weeks of amenorrhea were selected. Questionnaires were administered. After obtaining consent, data was collected and analyzed. So among the participants, the mean age and being employed dominated 52.1%, and monthly income of less than 500 Uganda shillings dominated 88.1%. Marital status, being married, dominated 96.4%, and the majority of the spouses were educated. Ugandan shillings dominated 68.6%. So in the study, we found that 81% of the participants were prepared, and they got more than 7 out of the 10 parameters. According to a study which was done in Ethiopia, the analysis was based on that study to define the level of preparedness. And 19% were not prepared. when we did to understand the factors associated with this preparedness, we found out that spouses' level of education was significantly associated with the preparedness of 81%, with a p-value of 0.002. And the spouse monthly income was also significantly associated with the preparedness, and starting antenatal care in the first trimester was also significant. We compared our study whereby the preparedness was good, 81%, and this was similar to a study which was conducted in Tanzania, whereby the findings were low, 63.5%, and this was due to a difference in the study population. The one in Tanzania was done among mothers who already been operated, and therefore we stand a risk of studies in Ethiopia, rural Kenya, and rural Rwanda. Our study was still had the best preparedness. However, identifying a blood donor was the least practiced among the participants, and spouse level of education, spouse monthly income were also consistent with other studies that were done by Gabriel. Compare and try to understand whether initiation of antenatal in the first trimester was significant. We found another study which gave the similar results in Thailand and Tanzania. Participants were well prepared, and this was due to the great work which was done by County National Referral Hospital Administration, and having a functional high-risk antenatal clinic boosts the preparedness, and also little attention is given to blood donation by compatible blood donors. In conclusion, all participants were prepared 81%. Identifying blood donors was the least practiced. Spouse monthly income, level of education, and starting antenatal care in the first trimester was significantly associated with background and professional readiness. Trying to implement reproducing these results of Kawempe National Referral Hospital to where I work, that is Hoima Regional Referral Hospital, we found out that according to the Ministry of Health report, which was being read to us, the mortality ratio for Hoima Regional Referral Hospital alone was 780 per 100,000 live births, and the neonatal perinatal mortality rate was 84 per 1,000 live births. So having this study result from my thesis, and also combining the problem we have at the referral hospital, he has just groomed us professionals to launch a war against maternal mortality and neonatal mortality. And this war will be anchored on 6 prongs. Number 1, that is accountability to God, and the institution, and also the public. Prong number 2, patriotism. Number 3, high levels of ethics and professionalism. Number 4, continuous quality improvement, in particular, respect for maternity care. And then number 5, research, innovation, and digital transformation. But our core value of the projects that we are going to implement will be based on the research, innovation, and digital transformation. And the results that we anticipate and even piloted, they are going to affect 1, individual behavior of health workers, institutional policies, national policy formulation, and also development of protocols, internal controls and external controls. I thank you by appreciating the work by my supervisors, Professor Miriam Nakalembe and Dr. Tom Simon. Thank you so much.
Thank you. Thank you very much.
Amidst the study, did you consider the mother's awareness about their risks that it may have contributed to the results, but also the health education during the antenatal and the cadres that are providing care to these mothers for antenatal as some of the factors that may have contributed to the results? Thank you. I'll spare John Paul.
Did you consider awareness of the patients being aware of the risk, and also the institutional factor like antenatal care education? Yes, we considered the awareness of the risk, and that one was part of our analysis. During the bivariate analysis, univariate analysis, it was significant. Bivariate was also significant, but when we went to multivariate analysis to get the significant factors, it had a wide confidence interval, and therefore it was removed among the factors that were considered to be significant by the panel that analyzed the results at defense. Then about the antenatal education, that's an institutional factor. Our study was purposely patient factors. So the institutional component of the preparedness, how the institution is prepared for these mothers, was not conducted. Maybe that's another area where someone can do a study to understand how Kawempe National Referral Hospital is prepared for these mothers. But on the side of the mothers, we got how prepared they are. Thank you so much.
You can go back to your seats, but stay around, listen to the other presenters. So we have the final round of presenters.
That is 34.8%. 40.6% were from facilities outside of Kampala district. So we found that Wakiso, PG, Mukono, and other facilities outside Kampala had 40.6% referrals into our facility. 46.5% were attended to within 30 minutes at arrival. Like when they arrived at Kawempe, within 30 minutes, they had accessed care. So the factors that we noticed mostly, we had labor complications, obstructed labor, ruptured uterus. These accounted for 58.3% of our referrals into Kawempe. 39.9% ended up having emergency section, and the others had normal deliveries. Of the referrals we received, we lost 1.3% of the mothers and 6.9%. Most of the referrals are coming in at night. And at night we have less manpower, there's less administration, and so, but that's when most facilities are referring to us in the night.